Good morning, everybody. Good morning and welcome to Medical Grand Rounds. As a reminder, next week we have the annual Edelson Lectureship, and we'll be hosting Dr. Ora Gordon, who will be giving the talk, The Changing Role of Genetics in Medicine, from Reactive to Proactive. Today, I am delighted to introduce Dr. Stan Cohan. He needs little introduction for many of you, and perhaps most importantly to me, he is passionate about education. He is a true role model when it comes to lifelong learning, reasoning, and curiosity. Dr. Cohan is a practicing neurologist and director of the Providence Multiple Sclerosis Center. He did his residency in neurology at Albert Einstein College of Medicine in Bronx, New York, and then went on to serve as chief resident at Georgetown University, where he became professor of neurology as well as pharmacology, as well as chair of the Department of Neurology before coming here to Portland. Here he has been founder and director of the Pacific Northwest MS Registry and is the director of neurological research for Providence Health and Services in the Oregon region. Dr. Cohan has published dozens of peer-reviewed articles, is a true leader in the field, frequently invited as a visiting professor and guest speaker from the local to the international level. We are thrilled to have him here today to share with us developments in the field as well as his own insights with regard to multiple sclerosis.
Thank you, Laura. Holy smoke. None of that's true. I'm very glad to be back to talk about MS, a topic in which I have enormous interest. And typically what happens, and I don't mean this as a criticism, people have to do updates in which they talk about a couple of newer medicines and sort of what's going on. And we'll do a little bit of that, but I thought I'd like to approach things a little differently today. And instead of just talking about newer medications, we'll talk about demographics, we'll talk about just a little bit, and we'll talk about pathogenesis, at least as we understand it, the key features of pathogenesis that are well accepted. And then, using that as a backdrop, try to understand the rationale behind medication development and where medications fit into our understanding of the pathogenesis of the disease. These are my disclosures for those interested in such things. Now, as I said, we'll talk about demographics of MS, talk a bit about epidemiology, and then I want to talk about some of the key, not all, but some of the key features of the pathogenesis of this disease, and then sort of see where therapeutics fit into this model. Now, multiple sclerosis is not an unusual or rare disease. There are probably around 500,000 people with multiple sclerosis in North America. The disease typically presents in younger people, adolescents, young adults, but actually can occur at any age. There's a growing awareness of the importance of this disease in the pediatric age group, and furthermore, we occasionally see a 75-year-old show up for the first time with symptoms of multiple sclerosis, but that's very, very rare. Now, for reasons that are not understood, this illness is much more common in women than men. In the 1960s, we talked about a 2-to-1 ratio. For the last 15 years, we've been talking about a 3-to-1 ratio, and based upon the data for the MS registry in Oregon, right now we're at 4-to-1, and we don't know why there is this rising prevalence of this disease in women as compared to men. Now, MS is not just a more common disease than you may think. It's also a very serious disease. And I don't know how many people are aware of the fact that it is the most common cause of serious disability in young and middle-aged adults in North America. Furthermore, it's an extremely dangerous disease. And on an age-corrected basis, the age-corrected mortality for multiple sclerosis is 3 times the general population. Now, the reasons for that is not the MS per se, it's the selective susceptibility to comorbidities in patients with MS that make them so vulnerable. So, for instance, in the younger MS patients, where suicides are very, very high because of depression, and then as patients get older, selective susceptibility to infectious disease and sepsis, cardiovascular disease, and pulmonary disease. Now, unfortunately, we're chosen people again. Multiple sclerosis is especially prevalent in the Pacific Northwest. Not all the reasons for this are understood, but some of them are. And where in the general population of the United States, the risk is somewhere between 1 and 1.4 per thousand, it's clearly 2 per thousand or higher based upon our registry data. In the state of Oregon, it's true in Washington, Idaho, British Columbia, and so on. Now, why should this be? Well, for one thing, the further from the equator you live, and especially the further from the equator you were born and lived until about the age of 15, clearly affects vulnerability to this disease. And this has been known at least since the end of the Second World War, and there are numerous studies that demonstrate very, very clearly that geographic location early in life is a very important regulator or contributor to the risk of getting this disease. People have looked for many, many explanations for this, thinking that perhaps certain microorganisms are more virulent in certain temperate zones, perhaps organisms only are present at certain latitudes, and so on. But where it turns out to be most likely a contributor is through its impact on vitamin D metabolism. The further away from the equator you live, no surprise, the less vitamin D you produce. The joke has been made that if you lay buck naked on Burnside in October, you will not absorb a single ultraviolet ray. And indeed, this is true, that people who live further from the equator have fewer hours of sunlight exposure per day. Because of inclement weather, they spend more time indoors, they wear heavy, more covering clothing, and on and on. And even within given geographic areas, populations which live outside, like rural people, farming communities, and so on, have a lower risk of this disease than people in the same latitude who live in an urban environment. So vitamin D production appears to be important. Furthermore, there is a load of very high quality epidemiologic studies that strengthen this argument, and more recently, biologic data that points to vitamin D as an important regulator of the immune system, specifically creation of immune tolerance. There are some 1,700 sites that have been identified, gene loci in which vitamin D has a receptor, and in many of these sites, the genes that they regulate the immune system. Now, as far as MS itself goes, there are now some 170 genes that have been identified that confer some degree of risk. No one is suggesting that multiple sclerosis is an inherited disease. But where genetics play an important role is conferring risk of getting the disease. One of the genes alone, the gene that regulates the major histocompatibility complex, and I'm going to show you that in a few moments, it in of itself confers 50% of the genetic risk of getting this disease. But again, it is not a genetically caused disease. This is not Huntington's chorea, but instead, genetic profile confers risk, which when interacting with environmental factors may confer further risk and select people who are going to get this disease. There clearly among different racial groups is a differential sensitivity to this disease, with Caucasians of Northern European heritage, i.e. Portland, state of Oregon, are people with the greatest risk, whereas sub-Saharan African heritage people and people of East Asian heritage not only have less risk of getting the disease, but actually the clinical phenotype varies among these different populations, once again pointing to the important influence of genetics in the face of this disease. Now, in North America, somewhere between 1 in 700 and 1 in 1,000 people are going to have this disease. However, again, pointing to the importance of genetics, a first-order relative, a sibling, a parent, or a child of a person with MS has 10 times that risk, 1 in 70 to 1 in 100. And if you are the dizygotic twin of someone with MS, your risk is 1 in 20. And if you are the monozygotic twin of someone with multiple sclerosis, your risk is 1 in 3. Well, this would suggest certainly, as you see genetic concentration here, that genes again play a very important role in risk. But it can't be the whole thing. I mean, look, 2 out of 3 monozygotic twins of people with MS don't get MS. Furthermore, I can tell you from personal experiences, and this has been written about a lot, even in monozygotic twins, frequently the phenotype of the disease varies between the 2 twins. So there are other factors that are not purely genetic, i.e. probably environmental, that contribute to the variability we see and why not every patient with a heavy genetic load for getting this disease indeed contracts the illness. Now, for years, people have looked at environmental factors that may be contributors. And one of these has been infectious agents. And a wide variety of viruses have been looked at, with a common characteristic of all of them is that they are neurotropic viruses, most of them within the herpetiform family. And where we've landed is with Epstein-Barr virus, the cause of mononucleosis. Why is this? Well, first of all, the incidence of mononucleosis in women who have MS is much higher. It's overrepresented in the MS population as compared to the general population. And women who get mononucleosis clearly are at greater risk for getting multiple sclerosis. However, there are other important features of EB virus. For instance, if one looks at the spinal fluid of recently diagnosed patients with MS, in the overwhelming majority of patients, the so-called oligoclonal bands, these abnormal immune globulins found in the spinal fluid of patients with MS, are directed against nuclear antigens of Epstein-Barr virus. Recently, studies looking at aggregates of lymphocytes, almost granuloma-like collections of cells in the meninges, overlying MS lesions contain EB virus DNA. So the story is growing for an important role of EB virus as one of the things that may be a trigger for setting off the clinical manifestations of this disease. And there may be others. There may be environmental factors, including various toxins in the environment. However, no one yet has demonstrated in any scientifically valid way any molecule that does this. Now, what about the biological pattern of the disease? 85 to 90% of patients will present with what we call the relapsing remitting pattern of disease, in which patients may have an acute relapse, upline, stability, and then recover. That's the remission. However, what happens more commonly is patients don't fully recover. And after each relapse, there is residual neurologic impairment. And over time, with repeated relapses, there is an accumulation of fixed neurological deficit. So key number one is, well, one way of dealing with this disease is to see if you can reduce or ablate relapses, because if you do, you may prevent this accumulation of fixed disability. Now, what happens to virtually all patients with the relapsing form of multiple sclerosis, especially those who are left untreated, is that they will go on to what we refer to as secondary progressive disease, in which, in addition to relapses, between the relapses they're getting worse, and eventually a point is reached where they only get worse progressively in the absence of any relapses. That's called secondary progressive multiple sclerosis. It is the most feared aspect of this disease for several reasons. Number one, when people go on to progressive disease, that's when the canes, the walkers, and the wheelchairs show up. This is the most devastating form of the disease. And equally disturbing and frightening is that we have no meaningful therapies for progressive disease. There's one medication that's just been approved for the treatment of primary progressive, which I'll get to in a moment, and time will tell how effective it is. But the overwhelming majority of patients with progressive disease are patients with secondary progressive disease. And to date, there is no FDA-approved medication or European Medical Agency-approved medication for these patients that's safe and effective. So we want to try to prevent this from happening. Now, in about 10 to 15% of patients, relapses never occur. They're progressive from the very beginning, and those are referred to as primary progressive MS. There's been debate going on for 30 or 40 years now whether or not this is a different disease than secondary progressive. I think it's not. I think if there's nothing that separates them biologically, nothing that separates them genetically, nothing that separates them in response to therapy. Now, this probably represents two distinctly different disease processes. There's little doubt that the relapses are the result of acute inflammatory autoimmune dysfunction-driven disease. However, most of us, myself included, think that the progressive form of the disease actually is due to neuronal and axonal degeneration. And the reason this may occur is that due to the repeated salvos of inflammatory injury that these cells sustain over the years, they have a shortened lifespan. And just somewhat akin to post-polio syndrome, where years after the polio, nerve cells start dying as a result of the injuries done during adolescence when they got polio. And something like that may explain progressive disease. It's an area of great research interest, but so far little in the way of therapeutic opportunities exist. Now, do people get secondary progressive disease? They sure do. So within just 5 years of developing relapsing disease, over 10% of people will be in the secondary progressive form of the disease. By 15 years, it's over 50%, and past 25 years, it approaches 85%. Now, you might say, gee, you're not 26 years, that's not so bad. Well, if you got the disease when you're 19 and you're in a wheelchair at 45, there's nothing so terrific about that. So this is serious stuff. And we're hoping that at the very least, we can push this curve to the right by aggressively and assertively preventing relapses and treating every single relapse that occurs, because at least if we can reduce the amount of injury, we may forestall, and maybe in some cases, we don't know this yet, completely eliminate the onset of secondary progression in some patients. Now, multiple sclerosis is an immune cell-driven disease. It is not an antibody-driven disease. And this, again, one of these arguments that's gone on forever. The overwhelming abundance of evidence points to abnormality in primarily lymphocyte function, which drives this disease. It used to be thought that it was primarily or almost solely a T-cell-driven disease based really more on animal studies than humans. We now recognize that both B-cell and T-cell lymphocytes, monocytes, and dendritic cells. Now, that's a cell type some of you may not be aware of. It has nothing to do with dendrites. Dendritic cells are referred to as professional antigen-presenting cells, and they're ubiquitously present throughout our body. They're found in the immune system, they're found in the gut wall, they're found in the central nervous system, they're found in the vaginal vault. And these are early recognitions of antigens, and they present antigens to the immune system, dendritic cells. Very, very important target, I suspect, now in immuno-oncology as a potential target for therapy as well. So this is a cell-mediated disease. And now let's take a look at this cartoon. So what I'm attempting to show you here is how a relapse takes place. And I'm going to talk about relapsing disease. First of all, it's the one part of the disease that we understand the pathogenesis best, and it's also the portion of the disease of which virtually all these medications are directed. So here we have a cartoon of actually a venule. And this is, we're going to say, is a memory lymphocyte, T-cell or B-cell lymphocyte. This cell already has a familiarity, has been exposed to an antigen, and is now sensitized to it. And it's traveling along in a venous system in the brain, and there's inflammation going on here. And because there's inflammation, chemicals called chemokines, sort of homing molecules, are being expressed on the inner surface of this blood vessel wall, which attracts this lymphocyte. The lymphocyte adheres to the wall, hydrolyzes the intercellular bridges, gets into the central nervous system. Now remember, this is an experienced lymphocyte. This has an antigen memory. If once in the central nervous system, this cell encounters antigen to which it's been programmed, it becomes activated. The result of that activation is, first of all, it will produce pro-inflammatory cytokines, which of themselves are capable of damaging tissue. It will directly attack tissue itself, but also will recruit and convert other lymphocytes and monocytes into pro-inflammatory cells through the release of certain trophic cytokines. So we already see some opportunities here where we may be able to intervene therapeutically. Now, we might be able to get rid of this cell, get it out of circulation. We might be able to block the migration of this cell into the central nervous system. And perhaps if the cell does get in, we can perhaps either make it blind to antigens in this nervous system to which it's been sensitized, or prevent it from producing these cytokines which recruit other cells, or prevent its behavior in attacking the central nervous system. So here we see already some therapeutic opportunities. Now, if we looked in the tissue of this make-believe patient, except this is a real patient, here we have a venule, and these are lymphocytes, monocytes, and a few plasma cells that have infiltrated the parenchyma of the brain. You may even notice here cells migrating through the wall. The venule, here's the smaller venule down here. So this is highly destructive. And if we did an MRI scan of the brain with gadolinium, and gadolinium lights up a lesion in the brain when there's a breakdown of the blood-brain barrier. And during acute inflammation, there is breakdown of the blood-brain barrier. So when you see a gadolinium-enhancing lesion, in this case, in the left frontal lobe, and a smaller one you might be able to see here in the corpus callosum, that means active inflammation. This is an active attack. And we always respond to active attacks by shutting them down with high-dose intravenous steroids. Why? Let me get rid of this. I hate that. All right. Can we have the lights off for a moment? Thank you. So what you're looking now is at immunofluorescent microscopy of the section of brain where there's acute inflammation. The yellow stripe is a normal axon, the red around it is myelin, and the areas of blue are denuded or demyelinated areas of axons. Notice here the myelin just being stripped right off the surface of the axon. The reason it's blue is because it becomes phosphorylated when it loses the myelin coat. Now, this is damage done to myelin as a direct result of acute inflammatory attack. Now, some of these may survive, and some of them may even partly remyelinate and function again in the future. But I also want you to notice this bleb here. This is a transected axon, which also occurs as a direct effect of this acute inflammation, and that's gone. That is a destroyed cell. That will never recover. Now, is this common? Unfortunately, it is. Now, this is a calcium stain, so all you see are axons here. And what you see is many transected axons extruding their contents. How frequent is this? On average, there are more than 11,000 transected axons per cubic millimeter of active inflammation in multiple sclerosis. Multiply that by size of lesions, numbers of lesions, and years of recurrent lesions, and it's no wonder multiple sclerosis has devastating effects on brain function and structure. We want to prevent this. One of the ways we can prevent it, again, is to shut down the acute inflammation. So when we have a patient who we know is having a relapse, when we have a patient who has an enhancing MRI scan, we immediately treat those patients with high-dose steroids. There's no such thing as an okay relapse, because every relapse, no matter where it is, will destroy scores of axons that over time will lead to cumulative deficit that could be devastating. All right. How do you make the diagnosis of relapsing multiple sclerosis? Well, first of all, there have to be acute episodes of neurologic impairment involving the brain, spinal cord, and or the optic nerve actually being part of the brain. Secondly, you need MRI findings typical of MS, and I'm going to show you such an MRI in a moment. And thirdly, in many cases, you resort to spinal fluid examination because what you have so far is equivocal in making the diagnosis, and what we look for there are what is known as oligoclonal globulins. These shouldn't be there. They're not directed against central nervous system antigens, and also increased in situ IgG synthesis. This is what an MRI scan would look like in a patient with MS, and I want you to focus your attention on the scan on the right side. And what you see is some fairly typical lesions for MS. Here's a periventricular pyramidal lesion. These are ovoid and perpendicular to the ventricles. And we have what's called juxtacortical lesions, lesions that lay just tucked in below the gray matter. These are very, very typical of MS. And if you see this combined with a patient who had an acute neurologic relapse, there's no question that that's multiple sclerosis in almost all cases. Now, what are some of the symptoms of multiple sclerosis? Well, they're protean. There are many, many symptoms of multiple sclerosis. And there is no specific diagnostic feature based on clinical presentation of this disease. It shares symptoms with many other neurologic illnesses. But there are certain patterns you see that certainly are highly suggestive. Visual impairment, especially painful loss of vision in one eye due to optic neuritis. Diplopia, vertigo, nystagmus due to brainstem and cerebellar involvement. Slurred speech, facial numbness, difficulty swallowing. These are all features of brainstem involvement that are commonly encountered in this disease. Weakness, clumsiness, spasticity, weakness of one limb, weakness of both legs, hemiparesis. These are all among the clinical features, the motor features of this disease, as well as very, very commonly sensory symptoms. It can be numbness, numbness in both feet. It can be numbness in one extremity, but it also can be pain, burning pain, electricity like shooting pain, cold tingling that's painful. People say they feel when they walk, they feel like they're walking on rocks or they're walking on hot coals. These kinds of positive paresthetic distortion of sensory input are very, very common in multiple sclerosis. And bladder and bowel dysfunction is one of the nightmares that MS patients have to face, especially with spinal cord involvement, bladder involvement being more common than bowel, but both can be involved. What I've shown you so far very quickly are some of the typical features of multiple sclerosis. These were all signs and symptoms of MS that were recognized long before there was MRI scanning. But with the advent of MRI scanning in 1987, a whole new world of insight opened up into the fact that there are many other important symptoms of multiple sclerosis that in many patients are the most important abnormalities they have. First of all, up to 90% or more of patients with MS at some time in the course of their disease will experience debilitating, life-changing fatigue, and it is directly from the multiple sclerosis, and it is unrelated to the level of otherwise physical disability. Depression occurs in over 40% of patients, clinically significant depression in over 40% of patients with multiple sclerosis. It again is endogenous. It is not the result of physical disability, and it is 6 times the overall national average for major depression in the United States. Cognitive impairment. Imagine you have a patient who you've been treating with medication. They're not weak. They don't have abnormal sensory symptoms. Their vision's okay, but they can't work because they can't multitask or concentrate. These kinds of cognitive difficulties are seen in approximately 50% of all patients with multiple sclerosis, and it's a special constellation of cognitive impairment, which we refer to as frontal executive dysfunction. Impaired short-term memory, difficulty with multitasking, difficulty concentrating and maintaining train of thought, speed of thinking. People get cognitive fatigue. They say, I start to read, and after about 4 sentences, I just have to stop. I just get this brain fog, and I've got to stop. And patients have difficulty remembering names of familiar people and words that they should not have difficulty remembering. This can have devastating consequences, especially now as more of our patients with MS responding well to medications are trying to stay in the workforce. Now, until 1995, there were no medications of proven efficacy for the treatment of multiple sclerosis. Since then, 14 medications have been approved by both the FDA and the European medicines agencies for the treatment of mostly relapsing form of MS. One of these medicines, a drug called ocrelizumab, which I'll touch upon in a moment, has been approved for a primary progressive MS as well. But almost all of these medicines' approval are for the relapsing form of the disease. Now, in relapsing disease, what should a medication do? Excuse me. Well, it should reduce relapses. We know we want to do that because relapse reduction will reduce accumulation of fixed disability. But we also want to see a robust effect on MRI scanning. MRI scanning is the most sensitive and most specific biomarker we have for the biological activity of this disease in patients with relapsing forms of MS. It is 10 to 20 times more sensitive than clinical presentation or clinical findings or history. So it's extremely important that if a drug is valuable, it must demonstrate robust regulation of disease activity on multiple sclerosis in the form of fewer enhancing lesions, fewer new and enlarging lesions, and so on. And of course, we want a drug to reduce the risk of sustained disability progression. In today's environment, any drug worth its salt has to do all 3 of these things and do them effectively. Now, when should you start treatment? As I said earlier, as soon as you make the diagnosis. Because the sooner you make the diagnosis, the sooner you will reduce future relapses with the proper therapy. And if you reduce future relapses, there's a wealth of data that already shows that you will reduce the risk of future disability progression. Let's go back to our cartoon again. Now, what we have, again, is this circulating cell. And I'm going to tell you that for the sake of the next discussion, this happens to be a B-cell lymphocyte for our discussion. It also could be a T-cell, but it will be a B-cell. And the reason I'm going to pick on the B-cell is because one of the important roles that B-cells have is as antigen-presenting cells to T-cells. Now, here's our cartoon B-cell. And I want you to recognize this arc is a magnification of this B-cell surface. And on this B-cell is expressed a receptor, and we're going to call it a cognate receptor. It specifically recognizes a specific antigen, in this case, an autoantigen. So let's again say that here's our B cell. It crosses the blood-brain barrier, and it has a cognate receptor that's going to recognize antigen should it encounter it. And it does. It ingests the antigen. The receptors are retracted. The antigen is hydrolyzed into smaller peptides, some of which are autoantigen peptides. And then that autoantigen peptide is going to be presented on the surface of the B cell by this major histocompatibility type 2 complex. And there's a cognate receptor on the T cell that recognizes specifically that autoantigen, which results, as you'll see in a moment, in the activation of T cells. Well, here we go. Here's another opportunity. How about we do something to get in the way of this? People have tried this therapeutically. So far, the results have been very disappointing. And to date, there is no agent that interferes with that step that has been of proven therapeutic efficacy. But there are others that have been, and we're going to get to those in a few moments. All right. So now we have, let's go back. We have presented a cognate antigen to this T cell. And this T cell is now going to get activated. It's going to become a proactive cell. And one of the things this proactive cell is going to do is it's going to release interleukin-2, which is a pro-inflammatory trophic cytokine that will lead to the activation of multiple cells and also recruit more cells and also promote mitosis of these cells. So this is a very, very important step in establishing the inflammatory cascade in MS or in a bacterial and a viral infection, similar pathways. This activation through this receptor, and I want you to notice this is what's referred to as the high affinity interleukin-2 receptor, and it's expressed on these T cells. Now, interleukin-2 actually is a rare molecule. There's not a lot of it around. And because this is constructed as a high affinity molecule, it's very effective at attracting what little interleukin-2 is available. CD25 is what confers the high affinity, and then CD122 and 132 are the ones that transduce the signal to affect the cell's behavior. But it needs CD25 to be a high affinity interleukin-2 receptor. And when that occurs, what we see is an upregulation of activated T cells to drive the inflammatory response. But the other thing that happens is it also upregulates regulatory T cells, which are it's a genetic line of cells, and it's upregulated as well. That's the counterbalance to the acute inflammatory reaction. There has to be a way of turning it off, not allowing it to go in perpetuity. And there's the responsibility of regulatory T cells to control that part of the process. All right, so now we have this activated T cell. We'll forget about Tregs for a moment. We're going to come back to them in a slightly different context. So here's our interleukin-2, interacts with our high affinity receptor, and now begins to activate cells. What happens as a result of that? Well, these cells may migrate and transform into several very dangerous cell lines. One of these is the Th1 type helper T cell, which will produce pro-inflammatory cytokines such as interferon gamma, tumor necrosis factor alpha, and also more interleukin-2 to keep the process going. Or it may go in the direction, didn't mean to do that, it may go in the direction of developing into a Th17 cell, a devastating pro-inflammatory cell, which creates a train wreck, and its pro-inflammatory cytokine interleukin-17, more tissue necrosis alpha, as well as the regulatory cytokines 21 and 22. All right, so we see some opportunities here for intervention. Now let's look at some of the drugs and see how they work. Now, what we refer to as the platform drugs, these were the first drugs that were approved, the beta interferons and glutarimer. And I hope you don't mind, just so that everybody knows which drugs I'm talking about. Some of you only know them by their brand names. I'm not promoting brands. But the beta interferons, I think you all know those. Glutarimer is Copaxone, okay? So what all these drugs do is they all reduce relapse rate. What all these drugs do to a varying extent is reduce disease activity on MRI scan, and at least in the case of the interferon betas, also reduce the risk of disability progression. They all have excellent safety profiles, very important in a chronically administered drug. However, they all have to be injected, anything from every day to every other week. So this has impact on quality of life, it has side effects, and very poor compliance. The other part of the problem with these medicines is they're really only of moderate efficacy. And fully a third of patients on these medicines will have discontinued them in less than 2 years of starting them. in some cases because of lack of efficacy, in other cases because of intolerable side effects or just needle fatigue, and they just don't want to inject anymore. What do? Well, they do the right things that we'd want in this situation. For instance, they cause a shift away from pro-inflammatory cell profiles to anti-inflammatory cell profiles. So instead of there being an upregulation of Th1 and Th17, for instance, there's what's called Th2. And there's an upregulation of regulatory T cells. There's a suppression in the production of pro-inflammatory cytokines, such as interferon gamma, tumor necrosis factor alpha, and interleukin 17. The increased production of anti-inflammatory cytokines, and interleukin 2 is the prototype of that group of molecules produced by regulatory T cells. And interestingly, some of these medicines, especially the interferons, may block the migration of lymphocytes from the bloodstream into the brain. And furthermore, interestingly, interferon beta also increases the production of vitamin D, which we consider a protective molecule in this disease. However, they are only of moderate efficacy, and that's their problem, in addition to the issues regarding quality of life. So patients really have been clamoring, very reasonably, for something other than injectables. Get us some oral agents. We now have 3 oral agents. They are fingolimod, dimethyl fumarate, and teriflunomide. Each of these medications reduce relapse rates, have robust effects on MRI changes, and also reduce the risk of disability progression. There are problems associated with each of them. In the case of fingolimod and dimethyl fumarate, there is a small but definite increased risk of patients developing progressive multifocal leukoencephalopathy, PML, a disease that many, if not all of you, are familiar with as a result of JC virus entrance into the central nervous system. And in the case of teriflunomide, there's the risk of increased risk of spontaneous abortion, so extreme attention has to be paid to being certain that someone who's pregnant is not taking this medicine. And because it stays in the body for up to a year after the last dose, if a person does become pregnant, we actually remove it, usually with cholestyramine, which can get rid of it in about 10 days. These drugs also have side effects, GI side effects, cutaneous side effects, and in some patients, modest elevation of liver enzymes. But they're oral medications and otherwise are well tolerated and a very important addition. Now let's see how they work. Now let's start with fingolimod. Sphingosine 1-phosphate is really a modulator, almost acting like a transmitter, a signaling molecule that's ubiquitous. It's everywhere throughout your body. And its receptor, and there are 5 subtypes of this receptor, are found in many organs. It's found in the heart, where sphingosine 1-phosphate receptors regulate AV conduction. It's found in the lungs, where it regulates airway tone. It regulates blood pressure by affecting vasoconstriction. And also, the receptors for sphingosine 1-phosphate are also expressed on the surface of B and T cell lymphocytes. So this cartoon is of a supposed lymph organ. So let's say this is a lymph node. Lymphocytes come in through the afferent channels, and on their surface they express the receptor for sphingosine 1-phosphate. Because of the concentration gradient of sphingosine 1-phosphate in the lymph node, it regulates the egress of lymphocytes, especially memory lymphocytes, also naive cells, but we're talking about memory lymphocytes. It regulates the egress of lymphocytes out of the lymphoid organ. However, if you block this receptor, and the little green dots represent the fingolimod, now what happens is the sphingosine 1-phosphate receptor is no longer available to sphingosine 1-phosphate. As a matter of fact, there's actually a retraction of the receptors into the cell. Now there is no longer any mechanism for the egress of memory lymphocytes. Therefore, they stay stored, sequestered within peripheral lymphoid organs. What's the result of that? Well, we have just taken this puppy out of circulation. So here we have a mechanistically driven drug. And there may be some other mechanisms of fingolimod's action to MS. But here we have a mechanism of removing circulating memory T cells and B cells from patients with MS by not destroying them, by just keeping them sequestered in peripheral lymphoid organs. All right, what about dimethyl fumarate? It's a unique mechanism of action, and it may have multiple mechanisms, and the one I'm about to show you may not actually be the one that's most key in MS, but it's the one that's best understood. Now, dimethyl fumarate promotes antioxidant production directly by regulating genes that are responsible for producing sulfhydryl-containing proteins and peptides. All right, so here we have a cartoon. Now, this gray circle is going to represent this neuron. And within the cytoplasm of this neuron is NRF2, which is an erythroid factor that is a gene regulator that promotes the production of antioxidant proteins and peptides. However, ordinarily, it is sequestered and held within the cytoplasm by a cytoplasmic bound protein called KEAP1. But during periods of oxidative stress, such as inflammation, NRF2 is mobilized and used to reduce oxidative stress to the cell. Where does dimethyl fumarate fit into all this? Well, dimethyl fumarate is absorbed from the gut and is almost instantaneously changed into hydrolyzed into monomethyl fumarate, which is capable of entering the brain, entering nerve cells, oligodendroglial cells, astrocytes, nerve cells, any cell. And what happens is it displaces the NRF2 from the KEAP1, which allows it to enter the nucleus of the cell, which in turn leads to the production of antioxidant and anti-inflammatory proteins to protect the cell from oxidative destruction. Molecules like tumor necrosis factor alpha increase oxidative stress, peroxidized lipids, and so on, and this protects against that. So this is the proposed, and it may not be the only mechanism, but this is the proposed mechanism of how this drug works in multiple sclerosis. We also have teriflunomide, and teriflunomide blocks the name of an enzyme I can never pronounce. And this enzyme, which we're going to call DIOID, and I'm going to actually show you its name later, and you'll agree with me it's not easy. High pyrimidine production by mitochondrial pathways, de novo pyrimidine synthesis, is required for mitosis, required for cell maturation. And in the case of highly active cells, such as our T cells and B cells during inflammation, are necessary for them to function. And what teriflunomide does is blocks that pathway. So let's again look at our activated T cell. This is a high output cell. This is a cell that's going to multiply. This is a cell that's going to produce large amounts of cytokines to stimulate other cells. And it's a cell which aggressively is going to attack tissue. So its requirements, metabolic requirements, are very, very high. And just to remind you, the activation of this cell will do what? It'll lead to the evolution of pro-inflammatory cascades with the accompanying pro-inflammatory cytokines. Now, if we look at this cell within the mitochondria, this ability of this cell to produce the pyrimidines it needs at the level it needs them is dependent upon this enzyme. And teriflunomide blocks that enzyme. And I had written down the name of the enzyme so you could see why I struggle with it, and for some reason the slide didn't pick it up. So you're going to have to go with DHODH. It's a dihydroiodorate dehydrogenase. I did it. All right? And it's that enzyme that's blocked by this medication that really leads to the downregulation of these pro-inflammatory cells. It also downregulates other cells that are active, like the lining of the gut, hair-producing cells, and so on. So we see some temporary hair loss. Many patients have gastrointestinal symptoms, and it's all a result of the impact of this drug on these the metabolism of these very, very active cells. But it works, reduces relapses, reduces disease progression, has a good effect on MRI disease activity. Cells have other ways of producing pyrimidine. There's something called the salvage pathway that doesn't require mitochondria, because cells do have to produce pyrimidine to stay alive, and they do so by this other non-high energy dependent pathway called the salvage pathway, which this drug has no effect on. All right, now let's go back again to our activated T cell. It's releasing interleukin-2. Interleukin-2 stimulates the cell to lead it to be activated. However, there are other receptors, and you see the activated T cells and regulatory T cells that are produced as a result of that process. However, there are other types of interleukin-2 receptors. One of them is called the intermediate receptor, and the mistake on this slide is that what I'm going to show you doesn't involve a lymphocyte, but another type of erythroid cell called a natural killer cell. And I'm going to get to that in a moment. But interleukin-2 is not a common molecule. It's produced in small amount. And the high affinity receptor, because of its structure, manages to grab most of it. And what does that result in? Well, you know, this cascade we've been talking about of pro-inflammatory cell development. Is this a therapeutic opportunity? Well, let's take a look. Oh, by the way, if you do manage to stimulate the intermediate interleukin-2 receptor, you produce something called natural killer cells. You upregulate natural killer cells. And that's what I'm going to return to in a moment. Now, teclistamab is a monoclonal antibody that specifically blocks in CD25. It blocks that molecule. As a result of which, there is an inhibition of the expansion of pro-inflammatory T cells. However, it also blocks the activation and expansion of regulatory T cells. And I think that is the reason why this drug is also associated with increased secondary autoimmune diseases of the skin, liver, lymph organs, and blood. So secondary autoimmunity is a major problem with this medication, and it is probably because by blocking CD25, it also blocks the evolution and development of regulatory T cells, which should impact that. Nevertheless, it's an extremely effective medication. Now, it has two pathways in which it reduces disease activity. One is obvious. It's blocked CD25. It therefore prevents this cell from moving in the direction of activation. But now it makes more interleukin-2 available for the intermediate affinity receptor, and that in turn results in increased natural killer cells, as well as a decrease in activated T cells and these phenotypes which are very, very pro-inflammatory. So therefore, what we see is upregulation of natural killer cells, and what natural killer cells do is they kill activated cells. So they destroy these activated T cells and B cells, a secondary pathway by which this medication may have efficacy in the treatment of multiple sclerosis. We also have what we refer to as the high affinity molecules, and these are natalizumab, alemtuzumab, and ocrelizumab. Ocrelizumab being the most recently of the approved medications for MS. Now, natalizumab is a monoclonal antibody, and it's a very, very effective drug. It's considered, if not the most effective, among the most effective drugs in the treatment of patients with relapsing MS. The problem with the drug is a serious risk of opportunistic infection. And PML, as a result of JC virus infestation of the brain, in patients treated for more than 2 years or more who have been exposed to JC virus, the risk is anywhere from 3 to 12 per 1,000 patients developing PML. 20% of these patients will die, and the remaining 80% will be left with serious neurologic deficits as a result. This is no small problem. And furthermore, approximately 50% of the population has been exposed to JC virus. So it's not a small problem in the MS population. Now, how does this drug work? Well, now I want to focus on the transmigration of activated cells through the endothelium of venules. Now, how does that happen? Well, it turns out that in the central nervous, lymphocytes destined to enter the central nervous system express on their surface a docking molecule called alpha-4 integrin. And alpha-4 integrin reacts with vascular cell adhesion molecule 1. This interaction activates proteolytic enzymes which dissolve into cellular bridges and allow this cell to migrate into the central nervous system. What does natalizumab do? It's a monoclonal antibody directed against alpha-4, so there can't be any transmigration, and this cell goes on to die within about 24 hours of spontaneous apoptosis. This is the only recognized mechanism for this drug in multiple sclerosis, and it is a highly effective drug, the problem being opportunistic infection. All right, alemtuzumab, been around for a long time. This drug was known as Campath, used by the oncologists for the treatment of leukemias and lymphomas. It's an anti-CD52 antibody. CD52 is widely expressed throughout the hematologic and lymphatic system, and it produces lysis of a wide range of cells, many of which participate in the immune process. You only treat patients twice, 5 consecutive days the first year, 3 consecutive days the second, and for many patients, that's all the therapy they seem to need. So that all sounds very, very good, except again, there's increased risk of secondary autoimmune diseases, especially of the thyroid, but also thrombocytopenia on an autoimmune basis, Goodpasture syndrome in a small number of people, as well as other autoimmune diseases, and in addition to which there's an increased risk of thyroid cancer. Having said that, obviously this is a word to the wise to be careful. Nevertheless, this is an extremely effective medication, and for the right patient with the right risk safety profile where the disease is so serious, this is a reasonable choice for some patients. How does it work? Well, again, there is a multitude of different cell types that express CD52, and alemtuzumab lyses them. Now, in the process of destroying these cells, and I'm going to show you the very, very slow rate of recovery, it takes up to 9 months after the first round of treatment for lymphocytes to reach the lower limit of normal. And there's been no treatment in here, just here. If you break down these lymphocytes, you see there are 2 major groups. There's B cell and T cell lymphocytes. The purple line is the lower limit of normal for B cells, and you see that they recover within about 3 months, then go down again with a second treatment. T cells never recover their lower limit of normal. So these very low T cell levels, again, may explain why we see so much secondary autoimmune disease with this medication. Nevertheless, an extremely effective drug. Lastly, ocrelizumab. Now, ocrelizumab is the smiling cousin of rituximab, a drug which, again, most of you have familiarity, an anti-B cell monoclonal antibody that, again, has been used for years to treat B cell lymphomas, leukemias, sarcoidosis, and a number of other diseases. This is the humanized version of this, therefore fewer side effects, less likelihood of developing antibodies against the drug. And it's been tested in a variety of controlled trials and is highly effective. It's the only medication that's received approval for the treatment of primary progressive MS. How well it does over time, we'll see, but it's really big impact has been in patients with a relapsing disease. It destroys B cells, but it only destroys B cells that express CD20, only requires 2 infusions a year. There are frequent infusion reactions, but they tend to be mild to moderate and diminish in degree with each subsequent infusion. So I'm just going to quickly put up the B cell line here. And we see that we have a progenitor B cell, then a pre-B cell, and then when we get to immature, mature, and memory B cells, we begin to see expression of CD20. However, plasma cells don't express CD20 and thus are not destroyed by this drug. So, if you will, the stem cell line is left intact, so B cells can recover if you stop using the medication, and antibody production, which should protect you against other types of infections, for instance, is not affected. It is just this portion of the cascade that's affected. Now, for the sake of our discussion, what does this mean? Well, antigen-presenting cells and activated cells are destroyed. And indeed, this drug has profound effect in reducing relapse rate, disease progression, and MRI disease activity. And this is just to show you there's the CD20 in the cartoon, and by both complement and non-complement lysis, these cells are destroyed, and they may not recover for more than a year after just a single treatment. All right, so let's take a look at these drugs. Let's stage them. The first-line medicines, interferon, betas, and glutaramine, very safe, do help patients with relapsing disease, but of limited value because of their less than ideal efficacy and side effects that lead to a large level of discontinuation. The oral agents are clearly a step forward, better quality of life for patients, better tolerance in terms of better adherence, but again, some risk factors that we do not encounter with the first-line drugs. Second-line drugs, natalizumab and ocrelizumab, put there again because of some risk issues, also expense, and the ease of administration of oral agents versus intravenous infusions. And then the third-line drugs, mostly because of their autoimmune toxic profile, are alemtuzumab and daclizumab. So that's the staging of the drugs. Now, I've spoken to this point about medicines we have, what we know, and this is not everything we know, but important aspects of the pathogenesis of the disease and how these medicines fit into what we understand about the pathogenesis of this disease. What does the future hold? And I'd like to take just a few moments to talk about that. We can produce more drugs that destroy more cells. There's no question about it. We can try to block the production of certain cytokines, although the strategies that have tried that so far have failed. And anti-cytokine drugs have not worked, nor have given anti-inflammatory cytokines in large concentrations, like interleukin-2 worked, interleukin-10 I mean. For instance, what you saw there were increased infections and even increased cancer risk by giving too much of an anti-inflammatory cytokine. I would suggest instead that where the future lies is in fine-tuning. If we can develop medications, and we have the technology to do it, that actually regulates the genes that produce these abnormal cells, the regulatory sites that make, for instance, a regulatory T cell incapable of recognizing a self-antigen and allowing autoimmunity to take place. All of these gene sites have regulatory sites. Can we fine-tune the amount of behavior of these cells so that they are in better balance, that there's a better balance between pro-inflammatory and regulatory cell activity so that we reestablish normal immune homeostasis? We have the tools to do this. We have, for instance, what are called antisense nucleotides. These are mirror images of gene loci that can enter a cell, enter a nucleus, and turn off a gene. But there are also regulatory sites. And our body activates and controls those regulatory sites. What molecules do we use to do that? Are there human molecules that we know activate, suppress, and regulate gene sites that we can use as therapeutic agents? Number one, perhaps to reduce toxicity and risk. And secondly, to try to, again, fine-tune, stop using hand grenades to kill mosquitoes, and try to fine-tune the immune system in such a way that we can prevent or better regulate these diseases with greater safety. I think the future holds that, and our colleagues who are geneticists really, I think, hold the key to the future, not just of this autoimmune disease, but all autoimmune diseases, by approaching it that way, just as the oncologists are doing just the opposite by trying to upregulate the immune system to make tumor cells, which so often are impervious to immune attack, to make them vulnerable. I'm going to stop there. Thank you. Are there any? I'll stop there, and if there are any questions, I'll be happy to answer them. Yeah.
I'll start, Dan. First of all, thanks for a really, really great, very compelling talk. So, my question is, given the sort of relapsing and remitting nature of this, it's a two-part question, actually. What drives the remission? Why does it shut itself down? What regulates this process? And the second question would be, given that this is, seems to be largely controlled by these circulating trophic agents, has anybody done any research in pheresis or something like that to try to clear some of these things out?
So people have used plasmapheresis as a therapeutic approach to patients with very, very mixed results. There actually is no scientific evidence that the use of pheretic methods improve the disease course, even though sometimes it'll improve symptoms in the short term, probably by removing these pro-inflammatory cytokines. And just as the destruction of these cells can lead to a cytokine storm, and sometimes we see symptom elevation, for instance, with the use of a drug like ocrelizumab, where there's a release of cytokines in these cells, just the opposite if you remove them. But there is no evidence at all that as a long-term therapeutic controlling agent that works. Now, as to why it stops because of regulatory cells. So I'll tell you about a very interesting set of experiments that were done. There's an experimental model of MS called EAE, and there's all kinds of varieties on this methodology. And you basically induce an MS-like picture. So cells that were in the inflammatory foci of the animals are sacrificed. The cells are removed from the lesions and then given to other animals having active EAE, and those cells turn it off. Why? Because they've been converted from pro-inflammatory to regulatory. Now, that's what's supposed to happen in us. You know, you get the flu for 6 days and then it stops. Yes, you've also destroyed the flu virus, but you also then had to turn off the system that did the destruction. Regulatory cells and their cytokines, anti-inflammatory cytokines, are responsible. Now, B cells, it turned out, are not genetically determined. Regulatory B cells convert from being active to becoming regulatory as a result, actually, interestingly, of the inflammatory process. T cells actually is a genetic line. These are thymic cells. They're a thymic regulatory cells that you are born with, that, for instance, are already programmed to recognize virtually all pathogens through what are called toll-like receptors. But these cells also have some adaptive characteristics. And it's the T cells and B cell regulatory cells that turn this off. And it is in one way of looking at autoimmune diseases is that it is a failure of the regulatory T cell and B cell population that allows this to continue, because these regulatory cells fail to recognize autoantigen and say to the pro-inflammatory cells, no, no, that's off limits. That's not happening. And that's also an area of active research right now. Yeah?
Dr. Cohen, early on you mentioned a vitamin D deficiency. Can we use vitamin D to slow this down?
Yes. So there are now prospective studies demonstrating, not just cross-sectional studies, demonstrating that you can control disease activity. Our population generally has too low vitamin D levels. Mike McCullough, who many of you know, who's a bone endocrinologist, first pointed this out, that what is considered physiological vitamin D levels in humans will prevent a 9-year-old from getting scurvy in London in 1879, because that's when those levels were determined. And it's been carried forth ever since as the level it should be. And it's really to their credit, osteoporosis researchers who brought to light the fact that we are very deficient in vitamin D. And whereas if you look on our lab slips, it'll say 30 is okay. No, we shoot for 50 to 80. And again, there are more and more studies showing that it's higher vitamin D levels that are protective. One terrific study that I'll tell you, an epidemiologic study that I'll tell you about, that came out of Scandinavia. Denmark and Norway have a pregnancy registry that they've had ever since the Second World War ended. And they have blood samples of every woman who's given birth to a child in those two countries ever since. And they have the samples. And they were able to demonstrate that vitamin D levels of the mothers during the first trimester of pregnancy determined whether or not their children would get MS. And what they found was that serum levels of 50 and above were protective. Subsequent studies, the American Vietnam Veterans Study, which also looked at the risk of developing MS later in life based upon what their vitamin D level was when they were inducted in the 1960s, again showed that levels above 50 and 60 reduced the likelihood of developing MS years later. I mean, the story just gets stronger and stronger. And so we supplement every one of our MS patients. And furthermore, there's seasonal variation. We tend to see our patients with MS every 3 to 4 months, so every time they're in the office, we check their vitamin D level, and then we adjust their vitamin D intake accordingly. And we would regard most patients, tell most patients that they should be on at least 2,000 units a day. Furthermore, if a person has MS, we believe their children should be on vitamin D as well. And we would like to recommend that pre-adolescent children receive 1,000 units a day. There's no evidence of any harm by these levels, and that once they reach teenage years, they go to 2,000 units a day, because there's, without question, evidence that this is bioprotective. Yes?
If there is a possible link with EB virus, has there been any look at either EB viral vaccination or EB virus suppression?
The problem with it is that 92% of the population is positive for EB virus. So that's why, again, it's not just EB virus. And furthermore, there are, without question, different neurotrophic strains, different pathogenic strains. And I'm not a virologist, so I can't sort of go further than that. But I think we're not going to get rid of EB virus. And I think that if we can do the other things, I think the EB virus becomes much less of an issue. And I think it would be less daunting an issue than trying to vaccinate an entire population against the ubiquitous virus. Yes?
Given the number of rather broad symptoms that a patient with multiple sclerosis may have, such as fatigue,
Yeah.
given the importance of trying clinicians should look for that really should set off an alarm?
Yeah.
That, hey, this person may have multiple sclerosis. We better move really quick.
Great question. So I'm going to answer two ways. First of all, there's a certain pattern to this fatigue, which seems to be almost unique. The typical MS patient tells you the following. I wake up, feel terrific, and then at 10:30 I hit a wall. I go take a nap for an hour and a half, and lo and behold, I feel better for about 2 hours, then it happens again. Or I go to work each morning, I get home, I'm exhausted, I go right to sleep, and my life basically is working, then going home and going to sleep so I can go to work the next day. So that's the kind of feature. It's not, these are people who don't have sleep apnea. These are people who are not hypothyroid. These are people who are not on fatigue-producing medications. It's that pattern of being hit by fatigue. Interestingly, there is now a project going on with biotin, which you're all familiar with. Biotin may, through its regulation of mitochondrial function, may be able to actually reduce or take away that symptom. And there's a study actually going on right now in which we're participating with very high doses of biotin to see if we can preserve or improve mitochondrial function, because we think it's mitochondrial failure in these people that is the cause of the fatigue. The same thing for people with depression. 40% of these people are depressed. Now, depression's all around us. You wouldn't call somebody MS just because they're depressed. But if they are depressed, keep it in mind. Keep it in mind.
I know we are at time for anybody who needs to carry on with their day. Great discussion, and please stick around if you have questions.
Thank you.